start the training, I'd like to introduce myself. My name is Lee. You guys are here with the Revive Survive Overdose Prevention Program and training. And Revive Survive is a 5-year SAMHSA-funded program that's here to address and alleviate the opioid epidemic within New Orleans. And so one way we do that is through providing these professional trainings along with trainings to our OHL clients. We partner with NOSAP, we do naloxone distribution as well. And this is our team. So Alicia is our outreach coordinator. She wasn't able to be here today, but she does the trainings at our OHL detox and residential programs, as well as our outreach efforts. I'm the project supervisor. And then Helena, who is the prevention department manager and oversees all of our outreach and prevention efforts. And OHL in general has a variety of programs, including our detox program, residential program, along with a variety of other programs, including housing, outreach and prevention, and our outpatient program as well. So now let's get into the topic in our training today of overdose prevention. So let's first address what are opioids. Opioids are substances that bind to receptors in the brain that manage pain. They've been traditionally used to treat both acute and chronic pain disorders, but what we found over time is that they are very addictive in nature. They increase tolerance increases very quickly in the body with the use of opioids, and it creates physiological dependence. So for that reason, they become very addictive in their nature. As a result, doctors and healthcare professionals are straying away from using opioids for long-term pain management because of their addictive nature. And so here's a kind of a list of some of the opioids you may come across. And so, just because somebody takes an opioid does not mean that they have addiction or opioid use disorder. Opioid use disorder is a diagnosable chronic disease. It's a primary relapsing and chronic brain disorder that changes kind of how the brain works. And so as a result, it causes addiction. Some of those symptoms include cravings, prioritizing opioids over other responsibilities. People will usually have consequences in their social and work life and really begin not being able to function healthy. Their relationships will deteriorate, things like that. It's currently affecting 2 million people in America. So it's a pretty expansive disorder that's occurring in our community. But we want to be sure that we talk about the individual when we talk about addiction. So we're going to go into a lot of different statistics, and it's very easy to kind of generalize what addiction looks like, or the opioid use disorder, or opioid epidemic. But we want to really remember this as a human condition that people are experiencing. So throughout the presentation, you're going to see quotes from one of our Odyssey House graduates, and it's just an opportunity to bring it home and remember that this is really impacting people's lives. So it starts here with, I was born this way and into generations of addiction and alcoholism. And so now we'll take a look at some of the statistics of the opioid epidemic. Currently, 27 million people worldwide are suffering with opioid use disorder. Again, that's diagnosable addiction. That is 3 times the size of New York City, so you can really see that it's impacting a lot of individuals. And if you take a look at the bottom graph here, I know it's probably hard to read, it's small words, but what's important to see is that this top bar in terms of opioid consumption is the United States. So the United States is consuming significantly more opioids than other nations. And this is in comparison to Canada, Germany, Denmark, Austria. And so you can see that our consumption rate is significantly higher. In the United States, 174 Americans are dying from an overdose every day. This is really drastic. Most nations have been able to bring that number significantly lower, so we have a lot of work to do here in the United States. And in New Orleans specifically, overdose fatalities have surpassed homicides. And so for a city that's known for its like murder per capita, gun violence, those things, for us to be surpassing those incidents with opioid overdoses is really, really significant as well, and shows, the need and focus that we should be spending on this. Some of these graphs, the things that I'd like to point out, here is a change within New Orleans of overdose rates. So from 2015 to 2016, it nearly doubled or more than doubled from 92 to 211. And then also in this graph here, it's hard to see, I know, but the most important part to notice is that in 2015, there's a major spike in overdose rates. And that's specifically a result of the introduction of fentanyl. And so fentanyl is a very, very, very potent opioid. It's traditionally used for like end-of-life care, chronic pain disorders, cancer, and it is, again, significantly more potent. People are using it in street drugs, heroin, pressed pills, fake pills, and if it's not distributed in a proper way, then somebody can overdose very quickly off of it. So they may think they're taking a dose of something they're familiar with, and then fentanyl is actually in it and results in a fatality. And so now let's talk about what an overdose is, or an opioid overdose is. So when somebody has a toxic amount of opioids in their system, those same receptors in the brain that control pain also control breathing. So they go into respiratory depression, meaning they're not getting oxygen to their brain, their vital organs, and as a result it can become fatal. Some of the signs and symptoms that are really important to be able to acknowledge and recognize are blue and ashy lips and fingers. Again, that's because of a lack of oxygen to the extremities. So you'll notice that. Dizziness or confusion, the individual won't be able to be woken up or they're unconscious. You may hear a gargling or choking sound while they're trying to breathe. Slow or weak or no breathing, and then drowsiness or difficulty staying awake. And I will repeat those because, again, this is very important to be able to recognize. So blue or ashy lips and fingers, dizziness and confusion, unconsciousness or can't be woken up, choking or gurgling sound, and slow to weak or no breathing. And then again, our quote: when I came to from overdosing, the change I sought was reversed. Instead, I had road rash down my face, neck, and shoulders, and my lips were busted and swollen. I was sick and I was shaking. I was alone and weary. I was tired. It became clear to me that I could not continue to live this way, and this was Sunday, August 3rd, 2014. And so, what is naloxone? Naloxone is a medication that acts as an opioid overdose antidote. So the way that it works in the brain, it also binds to those same receptors that control pain. And so when you administer it, it jumps onto those receptors and pushes all the opioids off. So the opioids are no longer attached to those receptors in the brain. As a result, that person's going to go into immediate withdrawal symptoms, which can be vomiting, shaking, irritability. Oftentimes people will be revived and very angry. So it's a very uncomfortable experience, and oftentimes people will need medical attention as a result of it. In addition, naloxone only works in the body for about 30 to 90 minutes. So opioids stay in the body much longer, and something called rebound toxicity can occur. So after 30 or 45 minutes, when the naloxone wears off, those opioids are still in the body, and then they rebind to the receptors in the brain, and that individual can actually overdose again. So for this reason, it's really, really important whenever administering naloxone to call 911 and be sure that medical attention is sought and that they receive that care. In addition, naloxone is safe to use on all ages. There's no misuse potential. There's very little side effects from it. And so we encourage everyone, if you suspect an opioid overdose, administer naloxone. It cannot hurt the person if opioids are not in the system. And so we recommend doing that. Even if the person, let's say there's opioids and benzodiazepines, both in combination are resulting in this overdose. If the naloxone is used, at least the opioids can be removed from that equation, and they're more likely to survive. And in the top right corner, you'll see the different forms that you can access naloxone. There's the IM version, which is just a vial of liquid. You'll need a syringe to use it, and that is put into the upper arm or outer thigh. There's the nasal spray, which is Narcan, and then Esvia, which is an auto-injector, and it's very much like an EpiPen, works very similarly to an EpiPen. And so we have a couple of those models here. After the presentation, if you want to take a closer look, feel free to come up and look at those. So now let's talk about exactly how do we administer naloxone. Like we mentioned before, medical attention is really important. So the first thing you'll want to do is call 911. You don't have to say that the person is overdosing from an opioid. Just make sure that you say the person is unresponsive or not breathing, because it'll kind of set that urgency for EMS to arrive in a timely manner. So after calling 911, we'll administer the naloxone. Depending on the form of naloxone you have, it's going to be a little bit different. There's an IM version that we saw in the vial. So you would draw all of the liquid in the vial. You don't have to worry about if there's air bubbles in it or anything like that, because it's a muscular injection. It won't make a difference. And you'll put that into the outer arm or upper thigh. If it is the nasal, which is also very easy to use, you'll lay the person flat on their back, tilt their head back, and then do one spray into one nostril. So what's important to know about the nasal one is that this one doesn't have it in here, but the dose is in like a little rubber container. And when you press it, it has one release point. So you don't want to like, ooh, let me see if it's working and try it out. You just one spray and trust that it'll work. One spray into one nostril. And then for the SVO, it's an auto injector. It'll speak to you. It gives you directions. It's also very easy to use. And that's injected either into the upper arm or outer thigh. So after you administer naloxone, you want to check on the person, see if they're breathing. If they are not breathing, then it's very important to perform rescue breathing at that time. So to do that, you would lay the person flat on their back, tilt their head as far back as you can. You want to make sure that their airway is open. Sometimes this is like awkward. It may seem farther back than you would expect. Make sure that there's nothing in their mouth that they could choke on. So if there's gum, candy, things like that, just clear the airway. Pinch the nose closed, and then give 2 breaths initially. After those 2 breaths, you give 1 breath every 5 seconds. And we'll watch a video in just a second to give more clarity on that. But after about 2 minutes, you're going to check the person, see if they've been revived. If not, give them a second dose of naloxone. Like we said, there's no misuse potential, so you can't give too much. So even if the person has not been revived, give a second dose. And you don't have to be concerned that you're giving them too much. That's not a thing. Let me pull up the video.
To check if the person is breathing, place the person on their back, tilt their head back, and lift their chin up. Then put your ear near their mouth and nose to listen and feel for breath sounds while watching their chest to see if it rises and falls over 5 seconds. Counting aloud with me. 1, 2, 3, 4, 5. If the person is still not breathing, check for a pulse. If they have a pulse but are not breathing, call 911 immediately. Tell the operator that the person is not breathing. Now you can start rescue breathing. First, make sure that there is nothing in their mouth or throat blocking the airway. Tilt the head back, pinch the nose closed, and lift the chin. Form a tight seal with your mouth over their mouth. Take a deep breath and gently exhale into the person's mouth. Start with 2 breaths, 1 second each. Their chest should rise, but not the stomach. Then give 1 breath every 5 seconds for 2 minutes. 1, 2, 3, 4, 5, breathe. 1, 2, 3, 4, 5, breathe. 1, 2, 3, 4, 5, breathe.
So again, after 2 minutes of rescue breathing, you would check on the person. If they're not revived, give them the second dose of naloxone and continue rescue breathing. It's really important, the rescue breathing again is really important because the individual is experiencing a lack of oxygen. So, the people have, ask the question, should they receive CPR at that time? That's not necessary because we're not trying to get blood pumping through them. Really the most important part is the oxygen that they're getting to their vital organs and brain. Okay, so after you check the person, hopefully they're revived. If you have to call or if you have to leave for any reason, even if it's a split second to call 911 or follow up on EMS, leave the room to grab something, make sure that you put the individual in recovery position. Again, when they're revived, they will be experiencing withdrawal symptoms that can include vomiting, and so it's really important that they don't vomit laying back on their back and potentially choke. So that recovery position, they're going to have one arm under their head holding them up and their knee on their side, kind of making sure that they're stable. So again, that position is really important. Even if you're leaving for a split second, make sure to put them in that position. If for some reason the individual who's responding is not able to stay while EMS arrives, we recommend that you put the naloxone dose that you've administered in front of that individual so that when EMS comes, they don't have to figure out what's going on. They'll automatically know the context of the situation and be able to respond in an efficient way. So now let's talk a bit about the local laws and regulations surrounding naloxone access and administration. There have been some recent changes. So one of them is the Good Samaritan law, which protects individuals who are responding to an overdose in a couple different capacities. The first is if there's any paraphernalia at the scene, they cannot be held criminally liable for that. And also if they're the individual who administered naloxone, they can't be held liable for any negative consequences that may have occurred. So both of those are important to be aware of. In addition, the naloxone standing order, which was passed in 2017, means that individuals can access naloxone without a prescription at the pharmacy, and it is covered and reimbursable through insurance. So 97% of insurance policies cover naloxone, and it could be as low as a $3 copay. With both of these laws, they are here, that is the law, but pharmacists may not be educated on the naloxone standing order. Law enforcement may not be informed about the Good Samaritan law. So part of our training is to really encourage community members not only to be informed, but to share this information and hold people accountable in those positions and roles. So we encourage everybody to go and access naloxone at their pharmacy, inform them if they ask for a prescription that you don't need it, there's a standing order. If there's any problems, you can call our outreach phone and we'll speak on your behalf as an advocate and communicate with the pharmacist to make sure that you can get that naloxone. And so, what individuals are at the highest risk of overdose? A lot of times people assume only individuals who take illicit opioids are at risk of an overdose. Things like heroin or other illicitly used prescription medications. But that is actually not the case. And research shows that there are several characteristics or categories that increase somebody's likelihood of an overdose. And I will read them to you. So the first one is if an individual takes high doses of opioids for long-term management of chronic pain. Again, this is legitimate use of opioids, but also increases the risk of an overdose. If they receive rotating opioid medication regimes, so different opioids used in combination, again, this could be legitimate pain management, but it also increases their risk. If they're discharged from an emergency medical care following opioid intoxication or poisoning, this may not have been an overdose, but poisoning if they were sick as a result of it. They're at high risk for an overdose because of legitimate medical need for pain treatment coupled with suspected or confirmed history of substance use disorder. And I like to kind of talk about this one a bit because this is a challenging place, especially for a lot of our clients who are in recovery or people who suffer with addiction. And so opioids have a legitimate use, right, for pain management. And we may all likely go to the doctor with pain that needs to be treated. And so this can be a really hard decision for people in recovery of when to use it. Like, is it legitimate to use? So it's a conversation we have with our clients quite a bit, and it's something to just be very mindful of as service providers and supporting individuals who may be in recovery but need opioids for a legitimate pain management concern. If they take certain opioid preparations that may increase the risk of overdose, such as extended release or long-acting preparation. So again, this is just a different kind of opioid, something that might be long-lasting throughout the day, a 12-hour slow release. If they take that in combination with any other substances, again, this will increase their likelihood for an overdose. If they complete a mandatory detoxification or abstinence program. And so again, we mentioned initially that opioids build tolerance and dependence in the body. So as somebody uses opioids for a long period of time, they're able to take more and more and more with the same effect on them. But after they abstain for even 1, 2, 3 days, that tolerance drops dramatically. And so they may assume that they could take the same dose that they were taking 3 days ago, but that dose is now going to have a much more powerful effect on them and potentially result in an overdose. So this is some really good education for individuals who may be using or are in recovery to be informed about. This is a harm reduction technique of like letting people know if you haven't used in several days, when you go to use, be sure to use less because your body's tolerance has decreased significantly. And so start slow. And similarly, if they were recently released from incarceration and have a history of opioid use disorder, they're also at a higher risk of relapse and overdose for the same reason, and that the change in tolerance. And so now we're going to do a little activity talking about the perception or the narrative of addiction in our community. So we often hear two narratives about addiction. One is that addiction is a choice, and the other is that addiction is a disease. And so as service providers and individuals working in the community, we really need to be able to respond and answer questions. And if people think addiction is a choice, be able to tell them, no, these are the reasons why addiction is a disease. And also be able to distinguish the difference between substance use and addiction. So I think a lot of times people kind of clump those two together. And substance use, there is a choice involved. But when it's addiction, there's no longer that choice. So we're going to break up into two groups. Let's do this first row, the first two rows, and the two back rows. And we're just going to discuss these narratives and ways that we can combat the narrative that says addiction is a choice. So come up with statements, thoughts, research, things that you know that will disprove that addiction is a choice. And then the second group is going to do addiction is a disease and supportive statements. So reasons how you can prove addiction is a disease. Does it make sense to everybody? Yeah. And so we want to bring up this conversation, especially as service providers, because it's important for us to educate the people that we're working with, you know, and so if somebody is suffering with addiction or if a relative is and we're helping them through that, just basic education often can support them through that process. It's also really important, these narratives are something that come up all the time, and so we have to question our own biases sometimes and really push to ensure that we're challenging ourselves and making sure that we're offering non-judgmental and kind of holistic care to that individual. And that means continuously challenging and questioning how our biases are seeping into different situations and making sure that we're checking those before we work with clients or individuals. So we kind of brought up language a little bit already, but we're going to dig deeper into that situation or that conversation. So addiction has been stigmatized historically, and as a result, most or a lot of people who are suffering with addiction don't receive treatment, or if they do go get treatment, they don't stay enrolled in that program or don't finish their treatment plan. And in addition, also don't seek primary health care services to the same extent because of the stigma that they receive. The feelings of shame, even if somebody's an injection drug user and they get an abscess, that could really turn into like a serious infection. You may have to, take off the arm even in like extreme cases. But people are reluctant to seek that care because of the stigma associated with addiction. So as service providers, one of our jobs should be to destigmatize addiction and destigmatize addiction treatment and services. And so one way we can do that is through the use of our language. Just like you said before, if people are repetitively told they're making a mistake, they self-identify that. It's my choice. I keep making bad decisions and bad mistakes. And so they're blaming themselves for that addiction. And so one of the first page on the handout that I gave everybody is a diet or like a tool that we designed to help shape our language. So on the first column is a lot of words that have been used clinically, traditionally, and thought as appropriate terminology, but over time we've seen that it's actually stigmatizing. And so we have an explanation as to why it's stigmatizing and why we shouldn't use it, and then words we should use instead of. So I want us to go around the room. If anybody has one, what I'd like us to do actually is choose a word that you currently use often, or not, maybe not often, but that you currently use. Take a look at it and the explanation as to why we shouldn't use it and alternate alternative language. So does anybody want to share what they found? I can start. I think one word that I used quite a bit before really digging into this was the word abuse, because substance abuse disorder was traditionally, or in the past, the clinical diagnosis. And so it was very common. I mean, that's like, you know, what you use, substance abuse disorder. And so I've had to really, really focus and slow down my language to be sure that I don't use that word, and I make sure that I say substance use disorder, or somebody's not abusing a substance, they may use a substance. Anybody else have one from this list? Yeah, go ahead.
Abuse addict. And I feel using it right now that we're talking about it, that's when I think using addict feels like you push the game or you shouldn't do it too.
Yes. Yeah. So we want to be sure, just like in a lot of other, you know, conversations that we have, that we don't define people by these things, right? So like, we don't call people criminals because they're not the crime, right? So same kind of concept. We want to make sure that we're not projecting the disease on them, that they are not that disease, and it is treatable. They're not stuck with it. It's not a permanent thing. There's a solution.
I think we, in this room, this is an AETC thing, right? I mean, we try and shift our language away from saying like HIV positive to people living with HIV. So this is like something we do all the time anyways, to be more person-centered, or ideally we're doing it all of the time anyways. So shifting away from like injection drug users to someone who administers drugs or who uses injection drugs, because again, just it separates the behavior from the person's identity.
Right.
I want to say, I mean, I don't use clean or dirty for people, but I have used that for needles.
Yeah.
Like, to say, well, they turn in their dirty needles and then we give them clean
Right.
needles. And
Right.
saying dirty is not great.
Yeah, we also don't want to associate it with filth. You know, this is not, I mean, it's just like remove that whole association of dirt. You know, it's not, I mean, it's not relevant. Any other thoughts?
I'm thinking about something almost this in our group language. And this, even the word that we're using here, education is a choice, I think a lot of times our clients perceive it more as a weakness that is inherent in them, right? So if they're saying, like you were saying, that sometimes they get from their family members or their friends that not necessarily it's even a choice that they're making, but it's some kind of inherent weakness in them. So finding the language to combat that idea of it being a weakness,
Yeah.
I think maybe can be helpful for our clients to have language around that, for us to have language
Yeah.
around that as well.
Yeah, well, there, I mean, when I think of addiction, I think of a lot of resiliency as well, you know? So that's definitely like a strength-based perspective that you can bring into that. Any other thoughts? Yeah.
About step back, but I feel like in charting, I often read substance abuse instead of dependency, which is when if I have to chart, that's typically what I like to write. Just because again, it insinuates a lack of control and like a willful lack of control that I feel like is really unnecessarily judgmental. And
Yeah. And I think, I mean, especially in clinical spaces, I think abuse is a word that is still often used. So that's the one, I mean, I brought that one up, I lifted that one up because it's still so common in clinical spaces. So it may be even educating our peers and our coworkers in a nice way. You know, we don't want to call people out, but just like, you know, having that conversation in the office and saying, well, is it abuse actually? I don't know. I don't think it is. And even the word misuse is a little, you know, people were starting to go from abuse to misuse for that reason. But even misuse is like, the person is doing that. The person is misusing. So one thing we recommend, harmful use. So because people aren't misusing prescription pills, if they're taking it for pain management. I mean, oftentimes people get prescriptions that say take as needed. You know, that's easy to do. Yeah. And so really harmful use, because when it starts resulting in these negative consequences, is when we can start to categorize addiction. So the next thing we're going to talk about is also incorporating trauma-informed care into our practice. So depending on your role, it may not be appropriate to really dig into people's traumas and do all that, but it's an important perspective to have when you're working. And so that perspective is just knowing that trauma impacts us in different ways. Trauma results in depression, anxiety, irritability, all of these different symptoms that people can seek professional assistance for, and they get a prescription, or people may self-medicate, and oftentimes self-medicate with substances. And again, that substance can turn into addiction, or that substance use can turn into addiction with whatever social context that's going on, around, or physiological, context. So incorporating trauma-informed care, SAMHSA recommends these 4 things, these 4 R's. So realizing the widespread impact of trauma and understand potential pathways for recovery, recognizing the signs and symptoms of trauma in clients, families, staff, and others involved with the system, responding by fully integrating knowledge about trauma into policies, procedures, and practices, and seeking to actively resist re-traumatization. And so these are really important concepts to keep in mind when you're working with individuals. Sometimes we may not even realize how we could be re-traumatizing people. Language can re-traumatize people. I've experienced it before when somebody, like that, I've experienced it, and people may not do it intentionally. They don't realize. And so again, it's just slowing down our work, our interactions with individual, and being much more mindful and present when we're doing that. And so we have another sheet here. We're not going to go all the way through it, but some of you may already be familiar with ACEs, the ACEs questionnaire. Show of hands of people who are familiar with ACEs. Okay, not as many as I expected. But so the ACEs questionnaire was a research study initially, but it dug into how childhood trauma or childhood experiences impacts health outcomes and impacts the likelihood of risky behaviors and resulting biological and physiological effects. So we're not going to answer all of these questions right now, but this is just a useful tool that you could look at later on. And on the backhand side of it is kind of an explanation of the results of that questionnaire. So the higher the number, the more likely people will have resulting consequences or side effects from it. So health concerns arise, obesity, things like addiction, smoking, all are correlated with that number of the ACEs score. So again, this is just a tool to help us be mindful and recognize the impacts of trauma with the individuals that we're working with, and just have a more holistic sense when we're working with people.
And I would just mention quickly too that our case manager training next month is actually focused on that. So
Yeah, so if you want to get deeper into this. Yeah. Awesome. So now I want us to talk a bit about harm reduction. Show of hands of people who are familiar with what harm reduction is. Quite a few. So an explanation I often use for harm reduction is any sort of policies, actions, or behaviors that are intended to reduce the likelihood of consequences from human behavior. So take, for example, when I go in the car every morning and I put my seatbelt on, I'm putting my seatbelt on not with the intention of getting into a car accident that day, but just in case I do, that seatbelt is going to protect me from injury, right? Traffic laws, stop signs, all of those things are, again, attempt to reduce harm. And so there's specific policies or principles that the Harm Reduction Coalition has put together for drug use and harm reduction, again, principles in that regard. So I want us to go through these. You have a sheet with the principles on them. I'll start, and then I'll either have some volunteers or voluntold, a couple people to read them as well. So the first one is, accepts for better or worse that illicit and listed drug use is part of our world and chooses to work to minimize its harmful effects rather than simply ignore or condone them. Any volunteers to read the next one? Yes.
Understands drug use as a complex, multifaceted phenomenon that encompasses a continuum of behaviors from severe harmful use to total abstinence, and acknowledges that some ways of using drugs are clearly safer than others.
Another volunteer?
Establishes quality of individual and community life and well-being, not necessarily cessation of all drug use, as the criteria for successful interventions and policies.
Calls for the non-judgmental, non-coercive provision of services and resources to people who use drugs in the communities in which they live in order to assist them in reducing and
Ensures that drug users and those with a history of drug use routinely have a real voice in the creation of programs and policies designed to serve them.
Affirms drug users themselves as the primary agents of reducing the harms of their drug use, and seeks to empower users to share information and support each other in strategies which meet their actual condition. You change that word, users. Thank you for lifting that up, Joe. Next, anybody?
Recognize that the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequalities affect both people's vulnerability to and capacity for effectively dealing with drug-related harm.
And does not attempt to minimize or ignore the real and tragic harm and danger associated with illicit and illicit drug use. So with these principles in mind, I want us to get into groups of 3 or 4 and brainstorm ways that we can incorporate harm reduction principles, not only in our personal lives and individually, but in agencies and in our professional and work experiences as well. So this could be behaviors that you start doing today for yourself, or again, on a larger agency level, policies or programs that can be implemented. So let's
Sure.
all right, guys, let's bring our focus back to the speaker.
We're excited at Crescent here to be able to provide syringe exchange, which is a form of harm reduction, but we have no programming that is not recovery based. So we need to have more psychosocial wraparound services that provide room for folks who are not potentially ready to quit yet, but who still need support. Also outside of just opioids, there's all sorts of other things, addictive substances out there where people still need a middle ground and sort of support, but there's very little access to that citywide. But
our recovery works program, we're talking about is all abstinence and drug abstinence. So people are not ready for that. And the syringe exchange doesn't apply to that, something that those people don't have. So there must be grants out there to apply for.
So providing non-abstinence addiction services.
just so people in the room know, there is one support group that's at Bellevue. You have to be living with HIV, but you don't have to be a resident there, and they are harm reduction based. They require an RSVP. Steve Loria, who works there, is the person to get in contact if you know anybody who would benefit from that.
I was going to say, we have had that, so in terms of like Crescent Care with Recovery Works, the abstinence thing was definitely an issue, right? Because there were also people who wanted to get off of heroin but wanted to still smoke weed, right? And it's like, you should help them get off of heroin, that shouldn't be limited. But we do have several providers who have been doing this really long online training to give out like medication-assisted therapy and do Suboxone. And so they are like going to start doing that for people that either can't make it to the Recovery Works meetings, because for some people too, childcare and work, like you have to go to a lot of meetings for weeks and weeks in a row in order to qualify. And so for people who can't either make it to that schedule-wise or aren't interested in doing abstinence, then they are starting to access medication-assisted therapy just directly with providers.
Yeah.
So they have started doing that.
Any other thoughts?
I think sometimes in the day-to-day working with clients, it can be like
you might be focusing on a housing issue, but like as case managers, sometimes we don't always ask our clients just straight, like during the assessment, like initial assessment, you ask about substance use and drugs and alcohol, things like that. But then that kind of goes away, and you might not, unless your client tells you, you might not ask and be like, I wonder if this person is struggling. And I'm just wondering if there's like good ways besides like a formal assessment and language of just besides being like, are you doing drugs right now? Which, you know, depending on your relationship with the client, might be the appropriate way to ask them. Because you also want to like differentiate, is this person experiencing like a mental health issue that's separate from substance use, or are some of these problems because of drug and alcohol?
Right.
I think one thing, I mean, as direct service workers, one thing that kind of I take home about harm reduction and its principles is like really treating the human as an individual. You know, we could do that in all of our actions and all of our interactions with people. So there are agency levels of like protocols and programs and, you know, things that can be implemented. But as individuals who are working to serve people and help people and support people, we can do that with every interaction that we have with them by being non-judgmental, open, keeping our biases away, you know, not recognize it, and we'll talk in just a second about recognizing the stages of change and supporting them where they're at. And so those are things that we can do every day when we work with people. So on that note, one more thought?
I just one more thought on that is that I work in cancer, so frequently my conversations with folks about harm reduction is how they're using around when they're getting treatment. So like if folks don't want to use, it's like how do we space out their use around treatment so that they're at the least risky space or they have the least amount of harm involved. So it's not saying you need to quit, but it's like let's be honest and have a relationship and like make a safety plan for you.
Yeah.
So that like you're using on your terms, but you're aware of the health education and the risks involved with any of the sets of choices that you're making.
And I think that's like fundamental is education, right? Because people can't make informed decisions without that information. So really educating and providing people information about addiction, about how to reduce harms, about safer ways to use drugs, all of that is allowing them to have more choice really in their life. And so that's really important to ensure that we're doing. And so it was brought up several times about people who may be using substances but aren't ready to abstain 100%, right? And so that's kind of leading into the next conversation of recognizing the stages of change. And so we're running very close on time. So we initially had a role play activity where we were going to practice that, but there is a sheet in your handout that you can take a look at and in your free time be able to practice. But it's really important, there's also a description of each one of these stages. So pre-contemplation, contemplation, preparation, action, maintenance, and relapse. And the definition of each one of those phases and being able to recognize where somebody is in that cycle of change is really important. Another thing that I think is important from this is to also work to destigmatize relapse or lapse. Lapse is when somebody doesn't have a full-blown relapse. They don't go into the, like all of the same behaviors, but they may have slipped in some behavior. And this is often just a part of the cycle of change. And so it really could be looked at as an opportunity to see where somebody can get stronger at, right? So maybe identifying new triggers or different things that we can support them in rather than like you failed, you know, because it's really not a failure. It's a learning process and a cycle of change. So in your own time, take a look at that worksheet and support your implementation of recognizing these stages of change. And then when an individual is ready for treatment, making sure that we're able to make the right referral services. So treatment could look like a lot of different things for addiction. There's medication-assisted treatment, which we've mentioned, and is becoming more accessible within our community. But there's also other services like child care services, vocational, education, mental health services. All of these are kind of holistically treat addiction. So in some way, you may already be a part of somebody's recovery plan or treatment plan. And so being able to recognize what services are appropriate for an individual and making those referrals. And so again, I'll mention that OHL has a medically supported detox program, and we've recently increased our beds to 40. So if you know anybody who is looking for detox services, you can make that referral. We also have a 28-day short-term residential program and long-term program. But in addition to that, we have a resource guide with a variety of different addiction services available in the New Orleans community. So you can take a look at that list. It's also in your handout. And again, depending on the needs of the individual, making those appropriate referrals. So again, if somebody is working full-time and can't take 28 days out of their employment to go to a residential program, you know, this is an opportunity to take a look at some other services that may be more supportive. Any questions? So I'll read this last quote, and then we have the post questionnaire that we'd like everybody to complete. We'll hand this off. And then once you complete it, we also have a certificate and a cool little swag giveaway for you for attending our training. So once you finish the questionnaire, just hand it to us and we'll give you those things. But I'd like to end with this quote. And some may have considered me hopeless and a lost cause. At times, I would have agreed. After struggling for over 25 years, I have found a new way to live and a purpose that inspires me to abstain from addictive substances. Over 4 years later, I do have a wonderful, sober life. Fortunately, the person who handed me that shot also carried Narcan. He saved my life. Without that life-saving drug, I would not have had the opportunity to detox, to rehabilitate, and to change. Where there is life, there is hope. And thank you all. I'll come get some of these.